It's keratitis. This is one of the biggest masquerade infections in the cornea. It can present as anything and everything. There's a lot of slides, mostly pictures, but when IQ comes up, I will stop. So, herpes infects is ubiquitous. It affects most of us. You've got the infection, you've got the seroconversion occurs earlier in life. 6% of the people who are infected will develop the primary disease, and only 1% of them it will be ocular. So it's a small number of the total, but because the numbers are so large, it is the commonest infective condition in the Western world. And the clinical presentations are of those three types listed over here. This pointer isn't working, you see. Let's go with this. So the primary neonatal, where you get intrauterine infection, it's very rare, but it's quite serious and usually it is an abortion. Then it will be primary in children and adults, and it can be recurrent. So these are the three categories. The neonatal primary type is in the non-immune host because obviously the child has not been exposed to the infection before. 80% is type 1, which means above, and then 20% is below the waist, type 2 herpes, and there is significant mortality and morbidity with that. The acute lesion that we will see affect almost every part of the eye, the adnexa, the cornea in the form of microdendris or serpiginous lesions of concave keratitis, and you can get stromal keratitis. So when you get stromal keratitis in the neonate, it is actually infection that has happened in the uterus, that they have developed some immune response to it, and you get a stromal immune-mediated disease. If you look at the primary ocular infection in the non-immune host, so this is the patient never been exposed, again all the same kind of involvement, the periocular skin, the adnexa, and then the cornea as well as the conjunctiva. These usually heal with no scar formation. These are the skin eruptions, which are vesicular eruptions. And you can see these kind of dendrites appear on the cornea. The skin eruptions are like this. You see vesicular rash, can be bilateral or unilateral, and you get a follicular reaction. So when you see these in young children, always think of primary herpes simplex keratitis. Then the recurrent one is the one where the patient has already had the infection, and now they've got another episode endogenously from the release of virus from the trigeminal ganglion, and that it has a different manifestation because it's now happening in an immune host, and again you get blepharitis, conjunctivitis. Keratitis can be epithelial and stromal, and this is what we are used to seeing: dendritic lesions, geographic lesions, and then you have the neurotrophic keratitis. The dendritic and geographic lesions represent active viral infection, active viral replication, and neurotrophic is non-infective but due to nerve damage. And these are some of the manifestations. Bear in mind that you can occasionally get perilimbal, conjunctival lesions as well, but they're mostly corneal. You can stain them with fluorescein, rose bengal, and you see that classical branching pattern. And after a while, as you see here, the fluorescein seeps under the epithelium, and it becomes fuzzy, telling you that the epithelium is loosely attached at that side. Then you see later on these ghost dendrites. Now these often we see them and we ignore them and we don't know what's happening. These are areas where there were dendrites. The protein of the virus has gone into the stroma. There's been an immune response, some subepithelial scarring, and that subepithelial scarring, which was in the form of the original dendrite, are called ghost dendrites and are reminiscent of a previous virus infection. So just to bear in mind, if you're going to do surgery on these patients, you have to cover them with antivirals, particularly if you're going to give steroids. And here's another geographodendrid, geographic on the top, like North America, and then the dendritic lesion. Usually this happens if you are treating patients with a lesion with steroids, they rapidly expand from a dendrit to a geographic lesion. And these are some other examples. Just to mention two situations here. If the immune response is reduced, either because of systemic immunosuppression or a systemic disease, then the virus flares up and is quite extensive, but it could be local immunosuppression as well, like in this patient with conjunctival adenocarcinoma, as a very rapidly expanding geographic dendritic lesion. This patient was referred as a persistent epithelial defect, but was actually a large geographic ulcer occurring at the periphery or mid-periphery of the cornea. So they can be confused for other lesions. One has to be always be careful. Look at the edges. If they're little fimbriated edges like these, then think of a virus infection, not clear-cut lines, which may be a persistent defect which is trying to heal. Now, coming to the cornea, the stromal bit of the cornea, this is an immune complex disease. Most of the time, it's a reaction to the virus rather than active viral replication, so that can also happen. And this can be in the form of immune rings, it can be in the form of interstitial keratitis and limbitis. One of the commonest causes of limbitis, limbal inflammation, is herpes simplex disease, and the next common is acanthamoeba. So always think of the limbus, and I'll just show you a couple of pictures. So these are immune rings. Immune ring is where the viral antigen meets the antibody that the host already has because of previous immunity. The antibody is seeping into the cornea where they meet in optimum concentration. They precipitate to form a ring like that and a ring like that over here. These are immune rings. They cause inflammation, hence you need to treat them. If you see a leash of blood vessels with stromal infiltration, haziness and edema, that is interstitial keratitis. Again, it's an immune-mediated response. Now, the thing about herpes, the dilemma is that all the immune-mediated responses need to be treated with steroids, and steroids will suppress the immunity, cause the active viral replication to come forward. So you have to always do both, balance steroids with antivirals. This patient was given steroids only, and then she developed a dendritic lesion over here. Just in that side, as you can see over there, is stained with fluorescein. So be careful of treating them with steroids only. This is an example of limbitis, a sector of conjunctival injection with localized edema over there, and you will see some ulceration. And that's again quite commonly, like I said, seen with herpetic disease and other manifestation of vascularization. So any scarring with vessels and there is thinning, think of herpetic disease. And then of course you test the sensations, and the sensations are reduced, then that's another factor giving you the clue of the diagnosis. When you have T-cell mediated stromal diseases, that's in the form of disciform keratitis and endotheliitis. The previous one was immune complex mediated. This is T-cell mediated, and like a discoid lesion in the center of the cornea. A lot of KPs at the back of the cornea over there, and you can see a lot of more KPs here. Or you might even see an Kodagus type line, and a line that then goes as a wave across the whole endothelium, but it usually recovers. The endothelium recovers with steroid treatment, unlike a rejection line where all the endothelial cells are destroyed. Metaherpetic disease is where you get this neurotrophic element. It's not active viral replication, but there is a lot of corneal hypo or anesthesia. The stroma is melting, and sometimes you can see almost the pre-descemet layer or the descemet membrane is bulging out. It has melted away extensively. So thinning is a huge feature of herpetic eye disease, and any, like I said, corneal disease where you're thinning, think of this condition. Melting can be deep, as you see over here in the corneal stroma, in the area of a dendrite, at which then went on to stromal keratitis, and then melting, and these can also perforate. So you see melting in the active stage and melting in the healed stage of the disease. This might be mistaken for keratoconus, but it's actually thinning of herpetic eye disease. And all these are examples of thinning, and when you see blood vessels with some lipid. The other factor you should remember is that the commonest cause of corneal vascularization is herpetic eye disease. And the commonest cause of lipid keratopathy is blood vessels caused by herpetic eye disease, not with other conditions. So these two things are very important. We were able to find these two facts from a large number of, over 500-600 patients of corneal vascularization that we've studied. So how do you diagnose? Of course, dendrites are the classical system manifestation clinically, but remember, zoster dendrites are also there, and zoster dendrites are elevated, unlike the herpetic dendrites, which are like a groove, an ulcer. And then you have pseudodendrites. This is acanthamoeba, again acanthamoeba dendrite, and this is of a healing corneal abrasion, as you see over here. So bear in mind that there are other conditions that can also give you the dendritic appearance. Perforation at the periphery can be due to the peripheral ulcerative keratitis group of conditions. They are not all herpetic, and often herpetic disease can be combined with these patients because many of these patients have herpetic infection in the past. They've got peripheral ulcerative keratitis, you're giving them immunosuppression, the herpes flares up, you keep treating only the peripheral ulcerative keratitis with steroids, the herpes goes unnoticed and spreads. So always bear in mind, they can be combined herpetic disease with immune-mediated autoimmune diseases, all with bacterial infections. You have in the laboratory, you do biopsy scrapes, you can do culture, PCR. All of these are helpful. A clinical suspicion is your mainstay, with corneal sensation being absent. There are a whole host of drugs that you can use in the treatment. Different countries have different drugs available. We have acyclovir and ganciclovir in the UK, but we have to specifically order trifluorothiazide if we need that. And of course, steroids. So these are the two groups of drugs that we will use in combination. Most commonly used in the USA was the vidrabine or the trifluorothiazide. Now, the herpetic eye disease study gave us some clues, and I will go to quickly because there are 10 of them. After resolution of any form of herpetic simplex virus keratitis, 1 year's treatment of acyclovir 400 milligrams twice a day significantly reduced herpetic eye disease during that time without a rebound up to 6 months afterwards, after stopping the drug. So, important point. So, what we do is all patients with recurrent herpes disease, we invariably give them 400 milligrams of acyclovir twice a day for a year at least, sometimes longer. And if you've done a corneal graft, and as long as they are on steroids, maybe 2 years, maybe 3 years, we give them, just to be careful that this is excreted by the kidney. If the kidney function is low, they can get toxicities, ototoxicity, hearing loss, or nephrotoxicity, so you reduce the dose in those people. There's no statistically significant difference between using acyclovir 5 times a day for 10 weeks in patients who are being treated with the topical treatment and steroids. And they use trifluorothiazide because they did not have acyclovir at the time. So oral does not help if you're already controlling it with topical. Steroids were significantly better than placebo in stromal keratitis. So stromal keratitis immune mediated, you have to give steroids. And if you did not give steroids, the recovery was delayed. By the end of 6 months, there was no difference between the steroid and the non-steroid groups. So steroids help, but always give them with antiviral. I keep emphasizing that point to get rapid resolution of the condition. But in situations like corneal grafts, we will not use steroids without antiviral prophylaxis, and you give the minimum dose and taper it as soon as you can. Treatment of keratouveitis or iridocyclitis of herpetic origin, then if you give 400 milligrams 5 times a day of acyclovir for 10 weeks, it had some beneficial effects. That was another point. There are a few, I won't go through all of them because in the interest of time, you can read them up, but there are a few of them that are important to remember, which I've already covered earlier on. Just also to remember, in zoster, we give 800 milligrams 5 times a day, double the dose of what we give for simplex kind of keratitis. What was interesting, contrary to common belief, psychological stress, sun exposure, contact lens wear, systemic illness could not be shown to be triggers for HSV reactivation. Although this was the finding of a study, many of us don't agree with it because we see a lot of patients who have these kind of trigger factors that cause the virus. And one very common in my practice I see is young women who have menstrual cycle related activation. At a particular point of the cycle, they get activation of the herpetic keratitis or keratouveitis, and they can preempt that and they can start their treatment every month just before that's going to happen and avoid that occurrence of that condition. So anecdotally these things do play a role. Number of past episodes of epithelial or stromal keratitis is strongly associated with the likelihood of recurrence. So somebody comes with a history of many previous episodes, those people definitely put them on long-term acyclovir therapy. And long-term acyclovir significantly lowers the recurrence either of HSVK, but more effective in preventing the stromal disease. So for both, you can use them. So that's the way we do the treatments. We've already covered that. But you often have to resort to surgical treatment, and there's a whole host of those, and this will be covered in many different ways. You can do mechanical debridement, surprisingly very effective in treating without having to use any drugs. Gluing if there's impending or actual perforation, amniotic membrane. You have to occlude these vessels, and I'll show you that and make one comment on that. And of course, when you're doing corneal grafts, often therapeutic or tectonic grafts, the recurrence rate is higher, so one has to bear that in mind. So here is one case from my days at the Wills Eye Hospital as a fellow. Very large branching ulcers. All we did was we debrided that whole area, took away the virus load, it healed, and it healed normally as though you had treated it with acyclovir, which would have taken almost as long for this to heal. So example of how debridement helps. Gluing for perforations, Dalia is going to talk to us about that. We've got amniotic membrane transplant. Look at this interstitial keratitis melting almost over here. You've got a desmetocele and 2 or 3 little patches of membrane, and then you stitch it on the surface with the large one so that the epithelium grows on the surface. And Dalia has shown us in the previous talk already how you can rebuild corneal tissue. So one thing about herpes simplex keratitis, which is, I mentioned, thinning with vascularization. So you can see this patient's got vascularization and thinning. If you try and close these vessels, which we do at times, they get sudden increase in accelerated thinning, and in this patient a little blister formed because of the thinning of the stroma after fine needle diathermy occlusion of this vessel. And that was done in preparation of this very large corneal graft that this patient needed. So bear in mind that occlusion of vessels by whatever means can cause increased progression of thinning. And here is what we do for that. We do fine needle diathermy. For the larger vessel, we just touch it with the monopolar quadrille, it occludes the vessels. Just to finish off, when you do a corneal graft, look for recurrence of dendrites not in the center but in the graft host junction, because all those nerves have been cut. The nerves are coming only up to here. They're shedding along the nerves, so you see recurrence in this region, not in the center, in the early stages. If you're going to do a graft, think of dark and not PK, and use interrupted, not running stitches. That's my summary. Just before the thank you comes up, but I have to say thank you anyway, which was my last slide.